It is my pleasure to introduce Dr. Walid Nassif. He is currently a chief psychiatrist at Atlanta VA Medical Center and director of inpatient psychiatry consultation service. He's a coordinator of psychiatry residents and medical student education at the Atlanta VA Medical Center. And he's also a coordinator and psych director, Consult-Liaison Fellowship and Geriatric Psychiatry Fellowship Program. He also has numerous teaching awards. Join me in welcoming Dr. Nassif.
Thank you for the warm introduction. Thank you for my friends here who invite me and value what I have to say. I think some of the faculty here have trained with me as CL fellows, and they were quite outstanding. I'm sorry they left me to come here, but it's a pleasure to come back. What I want to talk to you today about is a topic very dear to Consult-Liaison psychiatry. I'm a CL psychiatrist. I've been doing this for 30 years. And I can tell you that the number one reason for consult on CL for us is delirium. Whether the referring physicians recognize that that was the reason why the patient was giving them difficulty or not, we end up diagnosing delirium. And sometimes it's rule out depression, sometimes it's simply a capacity evaluation because the patient doesn't seem to be showing very good judgment or doesn't seem to be retaining medical information necessary for them to make judicious choices about their medical care. Sometimes it's behavior disturbance, sometimes it's psychosis, sometimes it's dementia, and we end up concluding this is delirium. I've come to see it so often that I often tell my trainees, any new mental status change in a medically hospitalized patient is delirium until proven otherwise. That's how common it is. And I'll explain to you why it can be somewhat misleading. First slide is something you are familiar with, the Montreal Cognitive Exam. This is one of 6 versions. Many of you may not know that we have 4 other versions like this one, and then a 5th version that is aimed for the blind, essentially deleting the first 2 sections because they can't see them. So it becomes purely a provider-administered test, and it's scored over 23, the MOCA blind test. But anyway, I have 3 test questions for you at the end, and I'm gonna view them in a minute, but this is actually a 4th test question, but I'm gonna want you to answer now. You've all learned about delirium in your textbooks in medical school and what have you, and it's often described as a disorder of attention, orientation, or consciousness, and so on. And there seems to be an enormous focus in the literature on attention and others. But my simple question here is, let's say you are evaluating someone you suspect of severe delirium, and you want to administer a Montreal Cognitive Exam. What sections or what elements of the cognitive exam do you believe the patient is going to show deficits in?
Would you like a volunteer?
Yes.
Who would like to answer?
Who would like to say, where do you think the deficit's going to show up? All right, it's intimidating, I know. But again, it's simply based on what I just said earlier, that there's an overemphasis on attention, concentration, orientation, and level of consciousness in delirium. And while those are true, the reality is a patient with severe delirium can have deficits in any and all of these cognitive functions. So much so that a patient with severe delirium may score 0 out of 30. And you could be easily led to say, okay, they have very advanced dementia, they can't even recognize a lion, etc. But the reality is delirium is a disorder of brain failure, of brain suffering. And if it's suffering severely enough, the patient may not be able to engage or get it right for any of those tasks. So while attention, concentration, orientation are important, and they're important for the diagnosis if you can demonstrate that at some point in time the patient did manifest those deficits, they're not the only ones, and you may or may not find them. You may go in a patient's room at 9 in the morning and they look fine, especially if you don't do a very in-depth psychiatric interview or a cognitive interview. They may be able to crack a couple jokes, smile, have intact language, answer appropriately about whether they're in pain or whatever. And I see this with my medical counterparts all the time. I go in and do a thorough evaluation and I come out and tell them, I think the patient has delirium or mild delirium or moderate delirium. And they're like, oh, he looked fine to us. We rounded on him this morning and he was fine because he answered all their questions. He did not look agitated. He did not look disoriented. He seemed to be attending to their questions. And in their minds, that patient does not have delirium. Wrong. It is wrong because at 2 a.m, they missed the fact that the same patient was pulling their lines, trying to get out of bed, saying they wanted to leave, was accusing the nurses of incompetence, was hearing people talking about them in the hallway. And that gets lost because at 9 a.m, they look good and they don't even remember what happened the night before. And these fluctuating symptoms of delirium are very common. I think all of you have learned that delirium is often a fluctuating disorder. So you may catch them at a good moment and they may do well. You may catch them at a good moment, they may do well for the first 3 minutes. And the more you test them, the more they tire out quickly. And pretty soon they're starting to make a lot of mistakes and get very frustrated. And that's another feature of delirium. The attention span is there, but it's very limited in time. And so are other cognitive abilities. So that's just to kind of put it back in context and explain to you that most of us who went to medical school think of delirium as the typical picture of a patient in alcohol withdrawal delirium. They're agitated, they're sweating, they're tachycardic, they're delusional, they're hearing voices or seeing things, they're restless, they can't sleep, they're tremulous, and that's delirium in our minds. But there are many other features of delirium that are far more misleading, and that's what I want to point out to you today. All right, let's very quickly, based on this introduction, look at these test questions, and we'll come back to them at the end after the talk. So an 87-year-old presents from his nursing home with new onset agitation, paranoia, and aggressiveness. He is afebrile, but his face is flushed, and nursing staff reports new onset urinary incontinence. The most likely diagnosis explaining his behavior disturbance is, and I said most likely, I didn't say the only diagnosis, dementia with behavior disturbance, delirium, delirium on dementia, or new onset delusional disorder. So on initial exam, same patient, he is oriented to his circumstances, appears angry but attentive, and he is able to repeat 5 digits forward for you. The diagnosis of delirium is therefore ruled out. True or false? I think I've already answered that question a minute ago. And what is your best initial approach? Obviously, there's a lot more to be done, but your best initial approach is to administer Haldol PO, BID, or Haldol IM, or keep the patient safe and obtain a UA and a chest X-ray, or give them Ativan 1 milligram IM. All right, let's go back. Delirium in the literature has taken on a number of names. People call it different things. In different textbooks, different specialties call it different things. And we can argue forever whether encephalopathy or delirium are the same thing. We're talking about an acute brain disorder that causes cognitive dysfunction. And over the years, people have called it many different things. Acute confusional state is probably the most commonly used alternative to delirium. Our colleagues in medicine and neurology love the word encephalopathy. And it sounds very fancy, very medical, but think about its roots. All it means is pathology of the brain. That's all it is. Encephalopathy is disorder of the brain. So it doesn't really tell you what are we talking about. And I often find that a patient who suffered, for example, in anoxic injury, they had a drowning accident and were resuscitated successfully, or had a cardiac arrest and were hypoxic for a long time and were resuscitated successfully. Years later, this patient is suffering from severe cognitive impairment and needs a lot of support. And neurology is still seeing the patient periodically and calling it anoxic encephalopathy. Okay, so is that a dementia or a delirium, or what are we talking about? The same patient on day 3 after the accident, when they were still in the ICU and recovering, is also called anoxic encephalopathy. Yet that latter patient may well recover fully. Depends on how long they were apneic, how much damage the brain sustained in that initial anoxic episode. And you all know you could recover fully from a drowning episode, particularly if you have a good brain to start with and the insult wasn't too prolonged. So if they recover fully, why did we call them anoxic encephalopathy? In the same patient who actually suffocated a little bit longer and who was 65 years old when this happened is now with permanent severe deficits. They're different. One was a transient confusional state, which you can call delirium because of anoxia, and recovered fully. And the other one is essentially a patient with permanent severe deficits that require external intervention to support the patient in their daily function. That is the definition of dementia in DSM. It's a loss of previously acquired cognitive function, severe enough to lead to functional impairment. That's really all it is in DSM. So I take exception with the word encephalopathy because it sounds very fancy, but it really doesn't tell you whether this is gonna reverse or not, whether this is permanent or not. I think the only benefit to that term is that it's often preceded or followed by the presumed etiology. We say anoxic encephalopathy, hepatic encephalopathy, Wernicke's encephalopathy, metabolic, infectious, which kind of helps you think, okay, this is what they think is the cause of it, but it doesn't really tell you if this is permanent or reversible or what is the anticipated prognosis. Acute brain syndrome is rarely used, but it described exactly what it is. Clouded state, many patients with delirium describe what they experience as almost living in a dream. A dream-like state, the oniric state in some of the old textbooks. You know, things are not quite what they seem, the timelines are very fuzzy, people don't look the same, they look older or younger, the place doesn't look quite like my home, and I'm not sure where I am, and you say you are a doctor, but I'm not sure I believe that, etc. It's all just very fuzzy. Pseudo-senility, presumably in contrast to true senility, which would be dementia. And then finally, the two that I see often, and I have exception with that too, anticholinergic psychosis and the famous or infamous ICU psychosis. First of all, they're not psychoses, they are deliria, both of them. And why do people call them psychosis, do you think? Because they present with psychotic symptoms. A lot of these patients experience either distortions of belief, which we call delusions, or distortions of perception, which we call hallucinations or illusions. And for that reason, people are very impressed with these changes. The patient is seeing things, hearing things, accusing us of malpractice or saying we're not really doctors and this whole place is fake, and you're talking about me and you just want to put me under to harvest my organs. I've heard all of this in the context of delirium. That's very spectacular and very marking on the staff working these patients. It's easy to say they're psychotic. And they are psychotic, but that's only a small symptom in the broader context of the acute confusional state. They are delirious, and in the context of delirium, they are experiencing delusions and hallucinations. That's very common in delirium. So we really shouldn't call them psychoses. The ICU psychosis is particularly problematic because that is the final diagnosis and the last thing they worry about when they are in the ICU. Post-op, a lot of patients develop confusional states, and then they end up in the ICU and they're very confused for a few days. Surgery, orthopedics, etc., don't seem very concerned. They all do that post-op, and that's just ICU psychosis, and we don't have to worry about it. That is wrong, and I think I'm going to drive that point several times today to say a delirium is not as benign as we might think it is, because we all learn that it's generally a reversible condition. But it is not so reversible in patients with pre-existing cognitive impairment or patients who already have a pre-existing diagnosis of dementia. You allow them to be delirious for 3, 4, 5 weeks in the ICU and beyond, they are never going to come back to their previous baseline. They suffer irreversible cognitive damage from a severe prolonged delirium. So it's important not to dismiss the condition as a normal development following medical hospitalization, particularly intensive care, but something that you need to pay close attention to, identify the potential contributing factors, and do everything you can to try to reverse it in a timely fashion, to shorten that delirium and hopefully prevent the patient from suffering irreversible further cognitive damage. So, ICU psychosis is not an acceptable final diagnosis. It may be ICU delirium, but you really need to go beyond that and try to figure out why are they delirious and what can we do about it. All right. There are multiple definitions for delirium, and they're very complicated, and they change from textbook to textbook. And like I mentioned earlier, they seem to often focus heavily on attention, on orientation, on level of consciousness. All of that is true. What I would like for you to think of is delirium is a syndrome of acute brain failure. And when your brain fails acutely, it doesn't develop blindness or hemiplegia or paraplegia or numbness or whatever. It develops confusion. It has a hard time integrating data, working with data, analyzing perceptions. They get distorted. That's really what delirium is. It's a syndrome of acute brain failure. And the practical clinical scenario that you may encounter if you see a patient in the emergency room, like the patient I just described earlier, the 87-year-old who comes to the ER, very agitated. So now you're wondering, is this patient just demented and has a lot of behavior disturbance because their dementia is progressing? Or is this delirium? Or is this both? And you are agonizing at the bedside because you're trying to interview the patient and they're not cooperative and they're kicking you out of the room and they will not engage in a Montreal cognitive exam, and you're desperately trying to get them to tell you where they are and what date it is and to repeat a few digits after you, and they won't. So you come out of there, and as a conscientious psychiatry resident, you say, well, I don't know what this is because they won't talk to me, right? I can't make a determination. I think it could be delirium versus dementia, right? And I hear this all the time, delirium versus dementia. And one thing I want to encourage you all to avoid that, because it's delirium plus minus dementia. It could be both, and it actually often is both in the elderly. And delirium is a frequent complication of dementia, as we will see in a moment. So how can you make the diagnosis? The patient won't talk to you or won't allow you to conduct a Montreal cognitive exam or any other cognitive test. Obviously, obtaining a good history is key. So if you have reliable collateral information that you can tap for that situation, the most simple question that will answer your dilemma is this what they looked like 3 days ago or a week ago? As simple as that. If the staff at the nursing home tells you, not at all, they're usually cooperative and smiling, they recognize me, this morning he didn't seem to know who I was, or they usually, are not aggressive, this is completely different for them, you got your diagnosis. A sudden loss of cognition over the course of hours to days is a signature for delirium. Acute cognitive impairment. That's all you need to do. Your task now is to try to figure out why, rather than agonize because you are not able to do 7 digits forward or what have you. I'm not saying don't. It's always very useful to get a baseline, ultimately, if the patient will cooperate with you. But keep in mind that if that patient is acutely delirious because they have a UTI or whatever, they're going to be far more impaired than their baseline. And if you don't have a good baseline, then you don't know really where were they at a week ago or 2 weeks ago. But if the staff can describe to you that this is a far fetch from what they are at baseline, you already know you're working with delirium. Okay. It's an incredibly common diagnosis, and I think some of these figures are understated. Up to 10% of all hospitalized patients will present delirium at some point during their hospital stay. And look at how that statistic jumps, depending on the studies, to 40 to 80% of the geriatric population will develop delirium. So right here, you can see that age is a significant risk factor for the development of delirium. Almost half of all patients with pre-existing dementia are delirious upon admission to the hospital. What does that mean? That means they are now suffering further cognitive impairment than their baseline. And of course, why is that happening? Because they're medically sick. They are being admitted to the hospital for some intercurrent medical problem, and that problem is causing them to be further impaired. So that's delirium on dementia. Delirium still kills. And how does that happen? Why would delirium kill? It doesn't kill because of the brain changes or the neurotransmitter alterations. Just think very practically about what delirium does in a general medical hospital. Patients are refusing vitals, refusing meds, refusing labs. They're kicking their doctors out of the room. They're being discharged prematurely because they are unpleasant and paranoid and accusing people of incompetence. So if they state, I want to leave against medical advice, we're very quick to present them with the paperwork without calling psychiatry to determine if they have decisional capacity to do so, et cetera, et cetera, et cetera. They suffer quite a bit of morbidity while hospitals, but also after they leave the hospital. Why? Because they don't remember the instructions, they misplace, they don't pick up their medications, they don't remember what they were told about alarm signals that should prompt them to call their doctor or come back to the emergency room, et cetera, et cetera. It leads to significantly more morbidity and mortality in patients with delirium. And for those who work in nursing homes or, similar facilities, memory care disorder facilities, this statement is very familiar. So-and-so is not acting like themselves today. We better get a UA or a chest x-ray. And that's before they've even developed fever or tachycardia or leukocytosis. The mental status change may precede all the physiologic changes associated with the onset of medical disease. And if you know your patient well, you come to recognize that. They're not acting like themselves today. We better get a urine. And please remember, the elderly are not able to mount the traditional physiologic responses to disease that we see in younger patients, such as fever or tachycardia or leukocytosis. It can be very sluggish, leading you to think, oh, there is no infection there, but there is. Just last year, I was involved in a peer review, very severe, sad case. A patient died from urosepsis, and about 5 days prior, and I was the only psychiatrist on the panel reviewing the case, they had obtained a UA, and it showed 187 white cells. And the attending said, oh, this is just a dirty urine because he doesn't have fever or tachycardia or leukocytosis. But the patient had been very agitated the night before and the night before that. And I said, a mental status change is a sign of infection, especially in the elderly. And the patient died 5 days later from urosepsis. So it's a very tragic case, but you can imagine how important it is to recognize that in the elderly, some of the traditional evidence of medical disease doesn't exist, and mental status changes are a sign of a new development, a medical development. Okay, we've already seen how old age is a risk factor. Pre-existing cognitive impairment, even when you do not have a formal diagnosis of dementia in the chart, patients who are in their 60s, 70s, 80s, at the VA, it's even earlier than that, may already have cognitive impairment that hasn't been diagnosed by anybody. Why? Because primary care physicians don't routinely administer cognitive tests. It's an uncomfortable test for a lot of patients. They don't like to have their nose rubbed in their deficits. And of course, family members not only don't administer MOCAS to their loved ones on a regular basis, but also often engage in the same defenses that the patients do. Oh, he's just old, he's not interested in politics, he can't hear very well, he can't see very well, why would he know this information? He does not have Alzheimer's. No, grandpa doesn't have Alzheimer's. Because in their minds, Alzheimer's is this person who's curled up in bed, who's babbling incoherently, who's incontinent, etc. And grandpa doesn't have that. So people don't appreciate that this is a whole spectrum of grays, and it starts with very mild impairment all the way to this person who doesn't even recognize their loved ones anymore, and anything in between. Those patients who already have cognitive impairment have lost what we call cognitive reserve, this sense of plasticity or elasticity of your brain to handle outside insults and still be able to function normally is lost when you get old. And it's definitely lost when you start developing dementia. The loss of cognitive reserve makes you exquisitely sensitive to developing delirium from even minor insults. So the idea that a UTI never caused him to be delirious 5 years ago, but it is today, is perfectly plausible, because today his brain is not the same. As your brain ages, it loses that cognitive reserve, and that same UTI is going to have a widely different impact to your aunt versus your grandma, okay? So please keep in mind that it's a very fluid concept about what are the insults that can cause delirium. It depends in who. Who are we talking about? What is that brain like at the time the insult hits it? Does it have that plasticity or elasticity or not? Comorbid medical conditions is almost the rule in the general hospital. We rarely find that there's one cause for delirium and one cause only in severely medically ill patients. And that becomes the art of a good CL psychiatrist, is not to say, oh, the opioids cause delirium, or they just added a steroid the day before yesterday for COPD, and that's what caused delirium. You got to go through that chart with a fine-tooth comb and identify each and every possible condition that is stretching that patient's brain to the point of breaking. The camel's back. That last straw broke the camel's back when they introduced whatever, steroids or opioids, or they developed a UTI. But everything else had been stretching that patient until they snapped. So a good practitioner will look at the whole record very carefully and identify all possible contributing factors and try to attend to all of them simultaneously to try to shorten the course of that delirium. Do not jump to that conclusion because there's something that jumps at you that is very true, but there may be other factors that you need to take into consideration and attend to shorten the course of that delirium. Depression itself is actually a risk factor for delirium. Patients with the same medical conditions, for all other factors combined that are similar, those who have depression are more prone to developing delirium than those that don't, which is very interesting. It's almost like the depletion of essential neurotransmitters puts you at risk of snapping. And finally, hypoalbuminemia is something we always look at to see what the albumin levels are. If the albumin levels are low, that's a direct risk factor for delirium, presumably because it means that medications are no longer protein bound and they are in free form, which is the psychoactive form, and is more likely to cause toxicity. So your total Depakote level may look good, but if your protein levels are very low, the free Depakote level is actually very elevated and could be leading to some toxicity. So think about that when you look at the chart. Okay. Many of you are familiar with a lot of this. I'm not going to belabor it too much. Remember, attention can be impaired, but you may catch them at a good moment. Or if you put them to the test for more than a few minutes, you can start noticing that they're tiring out, that they're really exhausted. Their attention gets exhausted. They may have difficulty shifting and they start kind of mixing up the task. They go back to what you were saying before. No, that's not what we're trying to do now. Language is often impaired in delirium, and that's poorly appreciated. They start making mistakes. They have difficulty naming uncommon objects. And in severe deliria, patients can become incoherent, which we usually don't associate with delirium. We associate it with stroke, with aphasia, with maybe severe dementia, but we don't think that delirium, if it's very severe, can lead to that level of language impairment. Memory is almost universally impaired in delirium. Short-term memory is easy to test at the bedside, but often long-term memory is also impaired. That's not as appreciated. Short-term memory impairment leads directly to disorientation. You tell them what date it is or what happened 2 days ago, and 10 minutes later, it's gone. They don't remember, okay? 3D aspects are lost very readily, but in severe delirium, 2D aspects are lost as well. So that's something you can identify with most bedside cognitive tests. Incoherent thinking, very concrete thinking, inability to abstract or interpret proverbs, for example. Impaired calculations, which we often do serial sevens at the bedside. Impaired abstractions. Hallucinations and delusions are very common, and that's what led to this ICU psychosis or anticholinergic psychosis. Mood disorders are very common, and we often get a rule-out depression, and the diagnosis is delirium. It's quiet delirium or so-called hypoactive delirium. It's not what most of medical trainees expect. Like I said, most people expect an agitated, restless, insomniac, angry, paranoid patient. So when you see a patient who's quiet, not bothering anybody, staring at the ceiling or staring at the TV, but you could tell they're not watching anything, doesn't seem to be reacting too much to good news, doesn't seem to smile when their family members are there, it's so easy to jump to the conclusion that they must be depressed. It's horrible. They were just told that they had cancer last week. We just began chemotherapy, and they must be very depressed. Rule out depression, Consult-Liaison. We go in there, and the patient is scoring 12 out of 30 on the MOCA. They don't even remember they had surgery a week ago. They don't know why they're in the hospital. They're blah. And this apathy is actually another manifestation of delirium. One author said that patients who experience delirium may spend up to 30% of their time in a hypoactive state. We don't expect that as outside evaluators, but be cautious. Don't jump to the conclusion that they're depressed without doing a cognitive exam, is really the bottom line here. Okay, so you can have that psychomotor retardation. They can be agitated, they can have tremor, particularly in withdrawal or in hepatic encephalopathy, asterixis, also in hepatic toxicity. You can see it in toxic conditions. Myoclonus can be seen, particularly in uremia, anoxia, also for psychiatrists. Lithium toxicity causes a lot of confusion and a lot of myoclonus. And the confusion and the myoclonus may outlive the normalization of the lithium levels. Please be aware of that. The lithium may be normal and they're still confused, they're still a bit ataxic, and they're still having myoclonic jerks. That is very common in lithium toxicity. You're not necessarily missing some other dark neurologic disease. There are two reasons for that. Lithium is pretty offensive to your brain, and it takes the brain longer to recover from an insult than simply the removal of that insult. You don't recover right away. It takes a minute for the brain to bounce back. The other reason that you may not appreciate is that CSF lithium levels often trail serum levels. So the serum level may look normal, but the CSF levels are still very elevated and toxic. And that may take a few days to normalize. All right. Dysarthria and hypophonia are the two medical fancy terms to describe soft speech and slurred speech. Very common and very telling. So if you go in the patient's room and they're speaking very softly and their speech is a little garbled, ask again the same question. Is this how they talk normally, or is this a new development? And if it is a new development, you really need to suspect delirium. It's a common finding in the medically ill. Tone and reflex anomalies, nystagmus, which you can see in anoxia and lithium toxicity, in Wernicke's encephalopathy. Abnormal postures, which often lead to the false diagnosis of psychosis, or it's their schizophrenia acting out, and you need to transfer them to psychiatry, very common. Sleep disturbances are common. The phenomenon of sundowning, many of you have heard that. It is not specific to delirium. Many patients with just dementia without delirium also experience sundowning. They're more restless at night, they wander, they have, loss of environmental cues, the loss of the circadian cycle are pretty significant factors. EEG can be your best friend if you're disagreeing with your medical colleagues about whether the picture you're looking at is just exacerbation of psychosis, particularly if the patient has a known pre-existing psychiatric disorder like bipolar disorder or schizophrenia. They would love for you to believe that this is their schizophrenia getting worse all of a sudden in the middle of their ICU stay, and you need to take them to psychiatry. And you're going in there and the MOCA is 12, and that's not what they look like when they're delusional or how their psychosis manifests itself. You're saying, no, this is delirium. They're not gonna want to believe you. And you are left with one choice, actually, is to obtain an EEG. The EEG can be your best friend. If it shows diffuse slowing across all leads, it's a signature for brain suffering, and that's a signature for delirium. All deliria cause diffuse brain slowing on the EEG waves, except alcohol withdrawal and benzodiazepine withdrawal. Those are the only two deliria that actually show a rapid, excitable rhythm. All the other deliria shows diffuse slowing across all leads, so that could be really a very good tool. We don't get EEGs on every patient with delirium, only when there's diagnostic uncertainty. All right, perseveration in persistent Occupational pantomime, that's kind of a curiosity where people act like they're carrying out some elaborate activity in bed. There's nothing there, but they're driving a truck or they're pouring coffee and whatever. And you say, what are you doing? They get irritated with you. It's just a curiosity. It's a mix of delusions and hallucinations that make them act like they're engaging in some elaborate activity. What causes delirium? Remember what I said? It's a syndrome of acute brain failure. Anything that you throw at that brain that disrupts its normal function and its normal physiology can cause delirium, particularly in a vulnerable patient. So we can review some of them, and they're usually acute factors. They're not slow onset insidious factors. For example, uremia, only if it's acute can it cause delirium. If you go visit a dialysis unit, you may have 10 patients lying around there. They're not delirious, they're patiently waiting for their treatment to be over. Their creatinine is 11 and their BUN is 130, but they're not delirious. Whereas grandpa, who is not delirious at baseline, suffered a GI bug, and for the last 2 to 3 days has been vomiting and hasn't been drinking appropriately, and their BUN simply jumped from 11 to 38, and their creatinine from 1.1 to 1.7. Grandpa could be delirious just from dehydration and from the presumed GI infection. So that little bit of a jump in a vulnerable patient can be enough if it's an acute jump. So acute changes are not well weathered by the brain. Same thing with liver failure. Acute hepatitis, acute transaminitis can cause confusion. Otherwise, if it's very slow onset, it takes months of liver failure to develop hepatic encephalopathy, right? It takes really ammonia, that's very elevated, a total bilirubin that's very elevated before you become confused from hepatic failure. But an acute hepatitis or an acute transaminitis could really cause confusional symptoms. Same thing for cardiac and pulmonary failure. If it's well compensated, most people walk around with CHF, they're not delirious. But if acutely you become hypoxic or hypotensive in the context of a cardiac event, you could become delirious. You have to generally demonstrate that the brain got hypoperfused or hypooxygenated during the event to really document that actually the cardiac event is what caused the confusional state. Hypoglycemia, your brain doesn't like to be deprived of glucose. It's very essential. Hyponatremia, much more so than hypernatremia, low sodium. And as you know, low sodium alone in severe cases can lead to delirium and seizures, of course, and coma. Fever, your brain doesn't like to be heated, whether it's due to infection or not. Even just sunstroke can cause delirium. Hypothermia, doesn't like it. Hypoxia, it's a big one and a frequent one in a general medical hospital. And it often leads to very prolonged delirium. So even when you restore adequate oxygenation by putting the mask back on the patient or making sure the cannula is in place, they're gonna be confused for a while. And we see this often in chronic delirium. The patient is restless and agitated. Nobody wants to put restraints on them. And at night, they're pulling their mask 3, 4, 5, 6 times a night. And the nurse goes in there, Mr. Smith, how often do we need to tell you, you gotta keep this on? The O2 sats were 89. When she went in, she puts it back on, it jumps back to 92 or 93. All is well. All is not well. 10 minutes at 89, times 6 times a night, that patient's gonna be delirious all day next day or longer. So it has really a lingering effect. It doesn't correct itself the minute you restore adequate oxygenation. Endocrine dysfunctions usually are subacute, except perhaps in the case of thyroid storm. Toxicity is very common. We always look at the meds very closely. The biggest culprits in the hospital are narcotics, steroids, high-dose benzodiazepines, all anticholinergics. And here, I just want to caution psychiatry residents, please avoid those Vistarils that we love so much because they're not benzodiazepines and they're considered, benign anxiolytics or sleep agents. They're okay, but if the patient is delirious or if they have pre-existing dementia, that is a big risk factor to precipitate more cognitive impairment with anticholinergic. Hydroxyzine, diphenhydramine, oxybutynin, and many others, tricyclics and many others, can really put a load on the brain. The old H2 blockers are associated with delirium. Withdrawal, essentially from alcohol and related drugs, meaning benzodiazepines and barbiturates, not from anything else. Opioid withdrawal does not cause delirium. Patients are miserable. They are screaming bloody murder. They want help, etc., but they're not confused. If a patient who is an opioid addict becomes delirious on withdrawal, you need to look for another cause. They were either using benzos and they didn't tell you, or there's something else going on medically that you need to discover. So please keep that in mind. Definitely not cocaine withdrawal. I think most of you know this. So please, it's only alcohol and other GABA, agents. Infections, all infections, but particularly if they happen in the central nervous system, any intracranial processes, trauma, subdural hematoma, stroke, etc. And of course, in the ICU, the contribution of pain, sleep deprivation, the lack of environmental cues, the shifts working with equal intensity day and night can be pretty disorienting. It's not enough per se to cause an ICU delirium. Obviously, most house staff who walk in there or who stay there for even 24 hours are not delirious, but the patients are delirious, and you need to discover why. So how do you discover why? Careful review of systems, of the medical history, look at the vital signs, look at all the meds, including over-the-counter meds that they could be taking, and the PRNs. Sometimes people write something PRN, Q6 hours. Well, if you're getting Benadryl Q6 hours, you're going to be delirious if you're 75 years old. Or opioids, or benzodiazepines, or. So please look at that PRN list as well. Get the full standard medical workup. Each one of those is helpful. The CBC looking for infection, metabolic panel you're looking for kidney function, liver function, sodium, albumin, etc. Thyroid function test, ABGs to look for hypoxia, a UA to rule out a UTI, very common in the elderly. Blood cultures if you're suspecting sepsis or other bacterial infection. Sputum, a tox screen if you're suspecting withdrawal. And EKG that people ask me often, why an EKG? EKG only in the case of suspecting severe arrhythmias that could be impeding delivery of oxygen to the brain. HET CT, when you come empty-handed, we don't get a HET CT on every patient who is delirious unless we have good cause for it. They fell or they were in a fight or they have heavy addiction and they may have hit their head and never realized it. Or we did the full workup and we still can't find the cause. You better look in that brain. And the first thing I want you to think about that you're looking for, particularly in the elderly or patients with addiction, is a subdural hematoma. Because we're often also trained in medical school to think, okay, any brain mass, what you're going to need to look for is focal neurological symptoms, right? Focal neurological symptoms rank third in terms of the findings in someone with a brain mass. It's not number one. Number one is headache. Number two is mental status change. And only number three is focal neurological findings. And I also challenge you to be very honest with yourselves as to the quality of the focal neurologic exam that is performed in the emergency room in someone who's intoxicated or agitated or demented or delirious. It's usually, cranial nerves intact, A&O times 4, and that's it. That's the neurologic exam in the emergency room. You're gonna miss it, okay? So if you come empty-handed and you're still not quite sure why this patient is confused, scan them. EEG, like I mentioned earlier, can be very helpful. If you still come empty-handed and you can't figure out what it is, time maybe to call neurology, ask them to do an LP because you could be missing meningitis or encephalitis or some autoimmune disease. An RPR, that's rarely a cause of an acute mental status change. It's usually gradual decline with neurosyphilis. An abdominal film can be useful in the elderly, particularly if they have dementia. They may have a ruptured, a hollow viscus, or an acute abdomen, and again, may not be able to tell you I'm in pain, leukocytosis may be absent, the fever may not be there, and you could miss that. B12 levels, again, it's generally subacute to have mental status changes. Okay, so how do you treat? What's most essential, and I think I've made that point several times already today, is to really very carefully review your record, get a thorough history, make sure you're not missing anything that could be contributing to that delirium. So the essential point is to identify all the causes of the delirium, not just one cause, all the causes, and see what you can do about it. You can implement the traditional environmental measures. Many of you have seen those. They're kind of very standard for dementia, delirium, and any other cognitive disorder. Reduce unnecessary stimulation, reorient them frequently, allow them to sleep. You know, at the VA where we work, when you order labs for the next day, they're drawn at 3 a.m. 3 a.m., imagine that. And then there's the vitals checks, and there's a Q15-minute checks, and all of that. You're just really not allowing that patient adequate sleep. Encourage close family visitation as long as they know what's going on and they're not extraordinarily anxious or angry or upset with the patient because the patient is accusatory or what have you. Use clocks, calendars, stop signs, night lights, very important. So you start by eliminating what you can eliminate. Don't jump to just giving them Haldol or Ativan or whatever. You know, please think, what is it I can get rid of that could be an offending factor? That's very important. Reduce things that you cannot eliminate but potentially could reduce them or support them with non-offending. For example, painkillers can be perhaps reduced and you can add a non-steroidal or you can add Tylenol or whatever it is. If you're going to use neuroleptics, and remember, neuroleptics are still not considered a standard of treatment in delirium, although I think most CL psychiatrists, and I think my colleagues here will agree, we use them very routinely. Because sometimes you really have no choice, or the patient is very disturbed, very agitated, or very distraught by their own experience because of the hallucinations or the delusions, so we end up using them. There is some literature to support the idea that blocking dopamine in and of itself is actually very helpful for most deliria, regardless of their etiology, that there's a hyperdopaminergic state that sets in that you could actually treat by giving a dopamine blocking agent. And to that effect, I just want to remind most of you that Seroquel is not a dopamine blocking agent at low dose. We tend to love Seroquel because it has this aura of a benign and easily administered and well-tolerated antipsychotic, but it truly is not an antipsychotic at low dose. You really need to get into the 200 milligram plus range to effect any meaningful dopamine blockade with Seroquel. Below that, all you're doing is anxiolysis and sedation. So everybody feels good, the patient feels good, or they go to sleep and you think you're doing something, but you're really not tending to hallucinations and delusions or the core hyperdopaminergic state. So I'm saying avoid it here. I think you can still use it, but be aware that below a certain dose, all you're doing is just calming the patient down and allowing them to sleep better. If you're going to use dopamine blockers, use usually high potency, low dose. We use a lot of risperidone and olanzapine. Risperidone is not available IM, unfortunately. The only one available PO, IM, and IV is Haldol. And that is still the favorite agent in the intensive care unit. A lot of people don't like Haldol. It is fraught with a lot of side effects, as you know. It's one of the very early first generation antipsychotics, but it's very effective. And it's available IV in patients who can't take PO or in patients you don't want to be injecting 3 or 4 times a day every day. It's pretty cruel. Okay. You may use low dose short-acting benzodiazepines. Avoid long-acting because there's a risk of accumulation. Short-acting, low dose, I mean maybe 1.5 milligram equivalents a day of Ativan, no more. And that's usually only if you have no other choice, except, of course, in alcohol or benzodiazepine withdrawal, you may have to use them. You have to use them, not you may have to use them. But outside of that, avoid benzodiazepines because they are deliriogenic at high doses. They are contributing to delirium after a certain point. Patients with delirium may still develop coma and die. It's usually due to the underlying cause, but delirium complicates matters. As I mentioned earlier, the relationship to dementia, I introduced that very early on in my talk. Delirium is not as benign and as reversible of a condition as we might think it is, particularly in the elderly or the pre-existing cognitively impaired. It can lead to permanent cognitive damage. I've seen this happen so often in the general hospital in my career as a CL psychiatrist. Families get very upset. We brought them for appendicitis or for this, orthopedic intervention. and he developed complications. He was in the ICU for 3 weeks, but now he's better. Surgery is happy. The wound is sealed. There's no infection. There's no anemia. There's no bleeding. And he's ready to go, except he can't go back home anymore. He is so impaired now. He is literally heading for the nursing home. And the families get very upset. What happened? You're hiding something from us. What did you give him? Did he have something in the OR that you're not telling us about, etc.? And it may be none of those. Simply that he was extraordinarily delirious for 3 or 4 weeks in the ICU, and that means very bad news for your brain. So please keep that in mind. Treat promptly, identify the contributing causes, and work on them as best you can. Recovery may take days or weeks. It all depends on the etiology, but also who is the person who is suffering from the delirium. A 25-year-old is going to bounce back very quickly. 85-year-old grandpa, not so much. Particularly those with hypoxic events, with stroke, with lithium toxicity, are the ones that are going to have the most prolonged deliria, particularly if they are elderly or had pre-existing dementia. All right, so the 87-year-old who presents. Okay, so I asked you what is the most likely diagnosis. I did not ask what is the only diagnosis, the most likely. So the answer, according to me, is C, delirium on dementia. Why am I assuming he has dementia? I'm not necessarily confident he has dementia, but there's a good reason why he's in a nursing home to begin with. So unless he's very physically handicapped, he's gone to a nursing home because he can no longer take care of himself. And if that's due to cognitive deficits, that's the definition of dementia right there. Okay. Further, his age is highly suggestive of dementia. And I'm not saying that all 87-year-olds are demented. That's, of course, not true. But please remember, at age 85, 50% of the population has dementia. They're not tested by their family, remember what I said, or by their primary care physician. But if you actually put them to the test, they're really not able to function independently without difficulty, significant difficulty, some of them. All right, so he probably has dementia, and now he's coming back with new onset agitation, paranoia, aggressiveness, etc. So the most likely diagnosis is delirium on dementia. However, when you examine him, you're catching him at one of the peaks of his cognitive function, and you only ask 2 to 3 questions, and he was able to repeat 5 digits forward and seemed aware that he was, at your facility and that his family brought him there or the nursing home brought him there, and he's not too happy about it. So now you're saying he's oriented and he's attentive 5 digits forward. That can't be delirium. That is not true. If you do a full MOCA, he probably won't score more than 10 or 15. And if you do more testing or push him a little bit more, you will see how quickly he tires out and he is still delirious. And he may look far, far worse that evening or that night. Okay, remember, they may fluctuate. So you cannot rule out delirium based on one quick exam at the bedside. The history is more powerful than one quick question. Do you know where we are? And can you repeat these 5 digits after me? And you're like, yay or nay, and that determines whether he's delirious. The history is far more important. So how do you treat someone that you suspect of new onset delirium, who's also a resident of a nursing home and is 87 years old? The most common etiologies for those patients are UTIs and pneumonias, followed by a host of other things. You can't leave any stone unturned. You have to do a full workup. But before you rush necessarily to treat, identify the etiology and keep them safe, and start by getting a UA and a chest x-ray. You know they're delirious, let's try to figure out why. It is not wrong to give Haldol if he is very agitated or suffering tremendously from but that should never preclude you from pursuing it further and trying to figure out what's going on here and how can we treat the underlying etiology. So the answer would be C, possibly followed by A or even B. But again, initial approach is what I asked for here. Thank you for your attention. I think we have just a few minutes for any questions. And if you know about questions from the audience, if you wouldn't mind reading them to me or.
Yes, if you're viewing online and have a question, please enter into the chat for us. And then do we have any questions or comments in the room?
Yes.
Yes, here we go.
Thank you so much for the presentation. I think this is something we deal as an internal medicine resident. I think the most complicated patient to get admitted to your service is a patient with altered mental status or delirium. When you
I
talk
should
about
have
that,
added AMS to that initial list. It's a very popular term these days, AMS,
yes.
altered mental state, which
When
is
you
a
talk
lot
about
like
the
encephalopathy. Right?
when you talk about the role of albumin, I would say most of our elderly patients have low albumin when we get our CMPs. Do you have recommendations on how to treat that, or how do we go about?
I'm not proning hanging a bag of albumin for every patient who's delirious and who has an albumin lower than 3.5. Just use it to further your understanding of what could be an additional contributing factor. If it is profoundly in deficit, yes, of course, you may need to infuse. Outside of that, it's just for your own understanding. And if they are on medications that could be neurotoxic, in free form, then it might be worth trying to get a free level of Tegretol or Depakote or Dilantin or whatever it is, where you can actually order a free level to see if it is actually higher than it should be, and then adjust the dose accordingly.
Thank you so much.
Yeah.
Okay. Any other, oh yeah, hold on.
Thank you for the talk. It was very clear and easy to understand. I'm a second-year IM resident. I know that the dopamine blocking agents are, I guess, considered the first line for patients with delirium, but in a patient with Parkinson's disease, what would you suggest using? And let's say
That is,
elderly.
where, and I'm sure neurology is a big fan of Seroquel. That's almost exclusively what they use today. You do have other agents that are actually good dopamine blockers and have relatively lower extrapyramidal side effects like Abilify, aripiprazole. If you do use Seroquel, just be aware that if you're truly targeting psychosis, you need to push the dose up. And by then, you're starting now to dabble with the same issues that you would with a low dose other agent. Sometimes we have no choice, and we have to take the risk of worsening the Parkinsonism temporarily to alleviate suffering or reduce agitation in the intensive care unit and so on. But if we can avoid it altogether, that would be better. As you all know, that we still have a black box warning for the use of neuroleptics in dementia. A lot of these patients already have dementia, they're just delirious on top of it. And we end up having to really weigh risks versus benefits and justify our decisions carefully by documenting in the chart. But I know, neurology is using Seroquel almost exclusively now for psychotic symptoms in patients with neuropsychiatric disorders, and I can see why, but you all have heard why also, because at low dose, it's really not even touching the dopamine. So it feels like you're helping the patient, and the patient may feel better, the family may be happy that they're sleeping, but you're really not touching the core psychotic symptoms at low dose.
Okay, we have a question online. Dr. Glass would like to know, we get a lot of catatonic patients who do not respond to high-dose titration of Ativan and amidodine. We do not yet have ECT here. Do you have success with additional pharmacological agents?
No, and that's not quite a delirium question, that's a catatonia question. Yes, it's very unfortunate, that you don't have ECT, but trust me, even where you have ECT, it's a mountain to climb to convince the patient, their family, and even their treating physicians to agree to administer ECT in someone who is catastrophically medically ill and practically comatose from catatonia, and tell them we're going to do ECT and that's going to help them. I don't really have any magical solutions. Jessica, do you know of any literature? I know you worked with catatonia 2 years ago.
Hold on, let's get you the microphone.
Now you're on the spot.
The people online can't hear if you don't.
So we really do try to push the doses of benzodiazepine, but I think we typically usually use Ativan. So one alternative is to change your benzodiazepine choice. And then there's been some research on things like zolpidem. And we do, of course, use amantadine. But I would say the most difficult thing is when they first come in, they're usually not eating, and we're limited to medications based on available route of administration. So if they're not taking PO, you have to give things IV until they get possibly an NG tube, and you can give medicines that way. So it is challenging.
Okay, thank you.
Hi, Dr. Nassif. My question is, what has been your experience in seeing Precedex used, and your thoughts on the use of Precedex for any delirium, but specifically a substance withdrawal delirium?
I don't have a lot of personal experience. I think it's becoming one of the favored treatments in the intensive care unit by the intensivists, essentially. Maybe internal medicine is using it more commonly. You know, I think it's a cousin of benzodiazepine. So in withdrawal, it definitely is a very helpful agent. In some cases where the delirium is so severe that it's seriously interfering with the delivery of medical care, particularly in the ICU, with patients trying to extubate themselves or pulling their lines constantly or not allowing necessary medical treatment to be administered, I have frequently seen the intensivists resort to practically deep anesthesia to really calm the patient down until the underlying condition that is causing the delirium can be managed effectively. And then they use agents like propofol or Precedex, and that's effective, but keep in mind, you're really prolonging that ICU stay, and there may be no way around it, and be prepared for some consequences to that, cognitive consequences. Even if you save their life, their brain is not entirely intact. We don't use it in CL, and I don't believe other CL services use Precedex. It's really something the intensivists use. I don't know if there are intensivists here, but who would like to comment? It is very effective, but again, it only kind of defers or delays the true recovery and allows necessary medical intervention to take place, which may be totally okay.
Okay, we have time for one more question. You have a question? No? Okay, we have one comment online. Again, Dr. Glass, thank you, Dr. Nassif, for such a wonderful lecture. You are one of my best teachers in psychiatry, and I pass on your teachings to our trainees every day.
Thank you, Oliver. Yes,
Thank
you're
you.
an outstanding fellow too. Okay, thank you very much.
Thank you, Dr.
Much
Nassif.
appreciated.